Yeah. Good evening, Dr. Gite, Dr. Hiren.
Good evening, sir.
Yeah. I missed the last class, but now uh, Dr. Gite said that many students they want history taking and all things little in depth.
Yes, sir.
So this is the last class where we'll be discussing little about history also, because there is a standard case scrotal swelling and followed by CA testis.
Yes, sir.
So Dr. Who can be better than Dr. Gite in history taking? He will real squeeze them and tell them how to take it.
Yes, sir.
Maheshwari has come back.
Sir, still is in US मेरे ख्याल से.
Okay, he's still in US, eh?
हाँ.
And
वो एंडो यूरोलॉजी कॉन्फ्रेंस में कुछ एंडो रिसर्च पे टॉक देने के लिए गए हैं.
yeah. So he'll miss our last class. So Dr. Gita, this will be a last class. We'll, as you said, na, we will elaborate little and we'll ask more questions about the history taking. So it will refresh their MBBS and MS knowledge. So when, in case if they are asked such a question, they can answer it, because their exams are also very nearby and only this topic was left. So we'll finish this. I am requesting Ganesh Bakshi also to join, and then today is the last, and then all the best to them. They have to prepare. Their exams are, I think, on 28, 29, 30 of October.
Yes, sir.
So in first week of, first or second week, we can take a mock exam. We'll arrange it in SAIFI along with our PG updates.
Yes, sir.
So we'll finalize the date and we'll just tell them.
Yes, sir.
Right? Okay. Brijesh, where is your PPT?
Sir, I am presenting today. I'll just start the sharing, sir.
Okay.
Rahul is there, sir.
Okay, Rahul. So I'll just talk to Ganesh, requesting.
महेंद्र पाल भी शायद ज्वाइन करेगा.
हाँ, आप करते हैं महेंद्र पाल को फोन?
करता हूँ.
Shall I start, sir?
Just minute. If the Mahendra Pal is joining, 1 minute.
Joining the class but may not actively involved in ऐसा उनका. तन्वी को मैसेज किया था शायद.
महेंद्र पाल ने?
हाँ, महेंद्र पाल ने.
अच्छा, गणेश को मालूम नहीं था, but he is joining in 10 minutes. Okay. So I think I told him that first we will start with the history and how to do history taking and what are the questions they ask and the reasoning out that why you have asked such a question. So we'll just start with that, and then by the time he will join and we'll go to examination, diagnosis and other thing.
Mahendra Bhai's message, sir, is not well, so he'll maybe just observe.
हाँ,
हाँ,
no
sir,
problem.
he's joining but he may not actively knowledge.
Yes, sir.
Yes. So who is answering today?
Sir, today we have 3
Sir,
participants.
I'll be.
Acha, Atul is there. Who
Yes.
else?
Dr. Atul Gupta, Dr. Sachin Mohare and Dr. Solay Raj, sir.
Dr. Sachin, Dr. Atul, and
Dr. Solay Raj, sir.
okay, okay. He has not joined, na?
He has joined, sir. He has
Good
joined,
evening,
sir.
sir. Dr.
Okay, you
Sol.
can start.
A 52-year-old male patient presented with left scrotal swelling since 1 month.
Okay, fine. Atul.
Sir, I
So
would
whenever
like,
they, yeah, yeah.
yes,
So whenever we are presenting the history, just tell everyone that what are any history is given, how you are going to start.
sir, I would like to ask the onset or progress, any history of injury, alternation in size
No, no,
during
no, 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 no,
activity,
no. Atul, Atul, Atul,
pain. Yes,
Atul.
sir. Yes, sir.
Whenever he has given only one chip complaint, so
Mm.
you should start like I will elaborate the chip complaint,
Yes, sir.
keep some diagnosis in mind, and
Mm.
I will ask the negative history to rule out each one by one. ये
Yes, sir.
इसका शॉर्ट में आंसर है.
Yes, sir.
समझ गए. कोई
जी
भी
सर.
केस रहने दो, स्क्रोटल स्वेलिंग का
Mm.
हो नहीं तो कोई भी रहने दो, वट एवर में भी द केस, तो चीफ
Mm-hmm.
कंप्लेन जो भी है उसको पहले समझो हिमेचुरिया है तो हिमेचुरिया को इलेबोरेट करो, पेन है तो पेन को इलेबोरेट करो, या
Mm-hmm.
स्वेलिंग है तो स्वेलिंग को इलेबोरेट करो.
Yes, sir.
अभी स्वेलिंग का हर चीज पहले इलेबोरेट करना है. अभी स्क्रोटल स्वेलिंग मतलब एन नंबर ऑफ कॉजेस है, जैसे टेस्टिकुलर
Mm-hmm.
ट्यूमर से लेकर लिम्फोसिल, वेरिकोसिल, टेस्टिकुलर मैलिग्नेंसी, ट्यूबरकुलोसिस ऑफ द टेस्टिस, गम्मा ऑफ द टेस्टिस, ये
Yes,
बहुत
sir.
सारे कॉजेस निकल सकते हैं. हार्निया, हाइड्रोसिल, तो वो क्या 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 नहीं आएगा.
हाँ,
आप
बहुत
10-15
समझता.
तो नंबर मैं ऐसा ही गिना दूंगा.
मैं ज्वाइन
Yes, sir.
करेंगे
Yes,
जो
sir.
ऑलरेडी.
हाँ, तो ये एक लाइन पे अगर कोई पूछ रहा है तो वो सब डायग्नोसिस दिमाग में रखना है.
ओके,
Yes,
मैं
sir.
ज्वाइन करेंगे.
ओके.
Yes, sir.
So you have to ask duration of the swelling,
Yes, sir.
correct? उसका इजीली अपेयर होता है, डिसअपेयर होता है. कब पिंपल्स का कोई
Mm-hmm.
टू गेट आबो द स्वेलिंग है नहीं है, कब पिंपल्स है
Mm-hmm.
नहीं है. उसके बाद में
Mm-hmm.
स्वेलिंग का प्रीसीडेड बाय कुछ हिस्ट्री ऑफ ट्रॉमा है नहीं है.
Mm-hmm.
मैलिग्नेंसी और ट्रॉमा का कोई कोरिलेशन नहीं है. ट्रॉमा विल जस्ट मेक इट द स्वेलिंग इज आइडेंटिफाई करने के लिए इजी हो जाता है, लेकिन ट्रॉमा की वजह से मैलिग्नेंसी होता है ऐसा कुछ नहीं है.
Yes,
अगर
sir.
जब तुम वो ये सब चीजें हिस्ट्री के पॉजिटिवली मैलिग्नेंसी की तरफ जा रही है, तो फिर उसके
Mm-hmm.
लोकल एडवांस के, लोकल के मेटास्टेसिस के, उसके और हिस्ट्री पूछना पड़ता है. जैसे नेक स्वेलिंग है, गायनेकोमास्टिया, ब्लीडिंग गम से, ऐसे
Yes, sir. Yes.
एन नंबर ऑफ हिस्ट्री पूछना पड़ेगी.
Yes,
ठीक
sir.
है. तो जो भी तुम कर रहे हो वो सिस्टमैटिक,
Mm.
वो एग्जामिनर को सिस्टमैटिक लगना चाहिए. अगर तुम्हारे
Yes, sir.
दिमाग में 4 डायग्नोसिस है तो 4
Mm-hmm.
डायग्नोसिस के एक लाइन में लिख लेना. एग्जाम में जो भी जा रहे, कौन सी भी हिस्ट्री रहने दो,
Mm-hmm.
कौन सा भी केस रहने दो. ट्यूबरक्लोसिस पूछना है तो 5-6 सेंटेंसेस आना ही आना है. ट्यूबरक्लोसिस के लोअर यूरिनरी स्टोरेज सिम्टम्स है, कफ है, चेस्ट पेन है, एक्सपेक्टेशन है, ये सब चीजें पूछ ला.
Yes,
समझ,
sir.
वो एग्जामिनर को समझ आते कि यू आर आस्किंग फॉर ट्यूबरक्लोसिस.
Yes, sir. Yes.
नहीं तो एक सिम्टम्स इसका, दूसरा सिम्टम्स उसका, फिर वो कुछ पूरा गड़बड़ हो जाता
Mm. Sir, I would like to describe, being asked to about the history of swelling, sir. What is the duration? What is the onset? Is there any sudden increase in the size? How is the progress? Here it is only 1 month history is there. Any associated history of injury or alternation in size during due to activity or pain? It is dragging or meaning type of pain if pain is there. Then any loss of sensation associated is there or not? How is the contralateral testis normal or absent? Or if this swelling is compared, then next will be any other swelling in the body like legs, abdomen, neck swelling are there. Any history of loss of appetite, weight loss or generalized weakness, jaundice, anemia, any history of chemotherapy, radiotherapy, or any history of surgery, any history of mucosal bleeding, gum bleeding, cough, breathing discomfort, hemoptysis, chest pain are there or not? any history of orchiopexy done in the past, any history of gynecomastia is there or not, any family history or any personal history related which is significant, I will ask. Occupation is important. Occupation also I will ask.
Okay, Atul. So you said that there is you will ask about a sudden increase in the size of the swelling. So what are the
Yes.
causes of sudden increase in the size of the swelling?
Sir, if I am suspecting malignancy, then it is due to hemorrhage in within the tumor. It will increase in the size.
So one is a you said tumor, bleeding in the tumor.
Yes, sir.
Second,
Second, and if any history of trauma, then hematoma can be there. If non-malignant causes, we have to see then.
third,
Uh, uh, Third is extravasation of urine. If any trauma is there and urethral injury is there, then we can suspect extra
no, no. You are
sudden. But
saying
that will
no, no, no.
be only meaning unilateral, less chances of unilateral.
Atul,
So that will be
Atul,
How
bilateral.
many times
Atul.
you
Question is
saw
very simple.
urethra draining into scrotum? That is like very rare. I think you can say
Yes, sir.
secondary hydrocele maybe more common, secondary to whatever cause.
Next, Atul.
Sudden
That is,
increase. Yes, sir.
Atul.
Yes, sir. Yes.
What I have asked you is what are the causes of? See, please understand what examiner
Mhm.
is asking you.
Yes,
There is
sir.
a swelling,
Hmm.
and now you are saying there is a sudden increase in the size of the swelling.
Yes, sir.
So now, what are the causes of sudden increase in the size of the swelling? So you can say, okay, yes, I agree with you. Okay, there is a swelling. So there was a trauma to then
Yes, sir.
hematocele or hematoma has taken place, or there is a tumor, and
Yes, sir.
there can be a sudden increase in the size of the tumor because of necrosis and hemorrhage inside it. Correct?
Then malignant transformation can be other cause. If
Then
benign previously, then
sudden increase
uh,
in size, sudden increase in
uh,
size. So what
yes, sir.
else it can be? It can be infection.
Yes, sir.
Sudden increase. You are
Infection.
talking of sudden increase in the size, no?
Yes, sir. Yes, sir.
So the infection, abscess formation,
Yes, sir.
suddenly there is a pyocele.
Yes,
If
sir.
there is already existing hydrocele, tunica
Mm-hmm.
vaginalis hydrocele, and that infection takes place.
Yes, sir.
Epidermocolitis. See the infection. So think
Yes,
whenever
sir.
the examiner asks you, no, and in the exam, in your history taking, write it down. There is a no history of
Mm-hmm.
sudden increase in size of the swelling. The examiner may
Mm-hmm.
ask you, then what are the causes of sudden increase in size of the swelling? So you should write down
Mm-hmm.
A, B, C, D like that. Okay.
Yes, sir. Yes, sir.
Right. Now, so that is one thing. Now, second thing you said that there is a pain, associated pain or no pain. So, what are the
Yes, sir.
causes of the pain? Normally, which are the swelling which are painful and which are the swelling which are not having pain?
Sir, in among scrotal swelling, sir, hydrocele is
Which
painless.
hydrocele? Which
Uh,
hydrocele?
Sir, vaginal hydrocele will be
The tunica
painless.
vaginalis
Uh,
hydrocele,
yes,
correct?
sir. Tunica
Right.
vaginalis hydrocele will be painless. And then any hematoma is there organized, then it will be painless, sir. And
Uh-huh.
if
No. Don't say no. What you said is right. Tunica vaginalis hydrocele. Agree. That is
mm,
usually painless. Second thing is
yes, old
there can be a
hematocele,
complete hernia,
yes, sir,
complete
complete,
inguinal hernia. Correct.
yes, sir.
Now,
Then
usually
chronic epidermal orchitis can also be painless, and gamma is also painless. If
no,
vaginal hydrocele, if it is tense, then it will be painless.
and malignancy.
Yes, malignant.
Yep.
Among painful swelling, sir, testicular torsion, any acute trauma, hematoma is there, then it will be painful. And if we are suspecting malignancy, then torsion due to mass of the testis and hemorrhage in the malignancy can sometimes cause pain.
And infection.
Yeah, infections.
So sudden increase in size, torsion, as you said, there can be a sudden torsion, there can be infection, there can be bleeding, there can be malignancy, necrosis, and hemorrhage. Correct?
Yes, yes, sir.
The same way, what are the causes which are the swelling which are painless? Usually tunica vaginalis hydrocele or that for that matter any uh, hydrocele.
Yes, sir.
Then complete hernia,
Yes, sir.
inguinal hernia.
Yes, sir.
Fine.
Sir, Mahendra here. Can I say something?
हाँ
Yeah, yeah, please, Mahendra.
So, sir, whenever this question about testicular swelling, it is better to if we divide in three scenarios like painless or painful, second acute and gradual increase in size, and second associated with fever and non-fever. So if we divide in these, so automatically, sir, the division is clear and there is no confusion about the possible causes of the testicular swelling. One another thing, the cause can be non-testicular or testicular. So it may again, so it will be easy to remember actually, because what I observed uh, that the person who is answering, he knows everything, but he is not able to frame the answer in a proper way. So I think if we remember the things in by these classification or these subdivisions, it would be better to remember.
So Atul,
Okay.
just what sir is trying to say is that you need to be a little more organized
Yes,
and
sir.
make the classification. You know everything, but how you present it will make a big difference.
Yes, sir.
Sachin, you can also add, you can talk also whenever you want to say something. Huh? Sachin?
Yes, yes, sir. Noted.
Yeah.
And one more thing, when you are telling about the painful swelling, so I think instead of saying fever like infective, the most common is epidermolysis, right? So again, while answering, try to be more specific and more common to the less common. This should be the flow of the causes.
Yes, sir.
Yeah.
That is for every condition. Whenever you're presenting the case, from most common to
Yes.
least common. So that
Yes, sir.
should be, and every history taking should be a little streamlined. Don't jump
Yes, sir.
from this question to that question. If you're asking about swelling, finish everything about swelling. If you're asking
Yes, sir.
about pain, finish everything about pain. If you're asking about fever, finish everything about the fever. So if you go systematic, then examiner knows that you have evaluated everything. Suddenly you go
Yes,
to
sir.
pain, then you say something about fever, then you say weight loss, then you go to family history. Don't do like that.
Yes, sir.
Hmm.
Believe me, everyone, if you start practicing by this way and taking history and being systematic way, you will reach the diagnosis only by the history about 80% of the cases and investigation just to need to confirm your diagnosis. They will not make
Mhm.
diagnosis. They will just make confirm your diagnosis. So just try
नहीं,
to.
now practicing is difficult because time is less. I will advise कि take 10 common cases in exam and write it down कि what I am going to ask in sequence and mug up that negative history कि ये
Yes,
समझो
sir.
शेप लैडर है तो मैं ये सब चीजें पूछने वाला हूँ, वो लिख के उसका मगअप कर देना है. तो अभी
What sir is
प्रैक्टिस
what sir is saying, I 100% support it, because every time in the class I'm telling, if you are asking about hematuria, there should be 10 questions in your mind for hematuria. Those 10 questions
एग्जैक्टली.
have to come. Those 10 questions have to come. Then you will finish hematuria.
I will
If there is,
suggest all exam going student 10 cases तुम लिख के prepare कर दो खुद कि how and what you are going to ask in the exam, जो कि
sir,
commonly exam cases रहते हैं, सबको पता है.
sir is absolutely right. Now, when you come for mock exam, no, you prepare and come. If flank pain is there, what all you will evaluate? If hematuria is there, what all you will evaluate? Make that one protocol so that we can share with all students. All of you get together and share on the group. We will keep adding to that. If hematuria is there, what questions you will ask? If flank pain is there, what questions you will ask? If bleeding is
अदर
there,
सर नेक्स्ट इसके लिए लगा तो हम 4-5 लोग ही बैठ के लिख देंगे
जी सर,
and उनको शेयर
अच्छा
कर
आइडिया
दीजिए
है सर.
क्योंकि
So that
ये
अपना,
बहुत बार साल भर हम बता रहे हैं फिर भी बहुत सारी चीजें ऐसी इधर उधर हो
yes
रही
sir, yes sir. I will
तो
ask my residents, sir. आप अपना residents को बोलो, then we'll exchange it. Once we
एक्स
have finalized the list, sir, then we'll put it on the group.
एग्जैक्टली
So we'll make hematuria, we'll make pain, flank pain and ऐसा swelling, ऐसा ऐसा 3-4 टॉपिक को कर देंगे सर. So
चलेगा.
that it is easy for them to follow also.
Yes, yes. Okay.
Good idea, sir.
Okay, fine. So
Sir,
shall I
you
write
were
which are
you
the
were saying
doctor? Shall I write which are the scrotal swellings that comes into your mind?
Sir, first epidermolysis, chronic orchitis, hydrocele, um, hematocele, pyocele, varicocele, um, testicular mass, epidermal mass, epidermal cyst,
Hernia.
Hernia. Okay.
hernia.
Now can you Kiran, no? Who else is answering? Third,
Sachin, sir. Sachin here.
Sachin. Sorry, Sachin. Now,
Sir.
now in your OPD, which are the commonest cases you have seen? Can you tell me accordingly? Number
Sir,
one.
hydrocele, sir. Then
No,
hernia.
don't say hydrocele. Don't say hydrocele. Say
Okay.
tunica vaginalis hydrocele.
Okay, sir.
Okay, so tunica vaginalis hydrocele, that is the
Mm.
most common you have seen, correct?
Yes. Yes,
Second
sir.
common condition.
Or say
Hernia.
primary vaginal hydrocele. That means it is that only.
Yeah. Okay. Second.
Complete inguinal hernia, sir.
Okay. Third.
Then chronic
No, but
epidermolysis.
sir was asking scrotal swellings. If you're going to talk about hernia, it becomes inguinal-scrotal swelling. So don't
Yes.
mix the two.
Complete hernia may come to
Yeah,
scrotum.
sometimes, okay, you can say a
Yes.
complete hernia, sometimes it appears as a scrotal swelling. Okay, fine. Then third.
Epidermolysis, sir.
Okay, epidermolysis. Third. Fourth.
Testicular mass neoplasm.
Okay.
Pyocele also.
No, have you seen pyocele? How often you have seen pyocele? Before that, what else you will see?
Tuberculous orchitis.
Okay, but before that, more common.
Torsion testis, sir. That will be acute present.
Okay, torsion, varicocele, and then you can talk of all other different
Yes,
conditions.
sir.
Huh? So always talk what is the most common that you see every day.
Yes, sir.
In OPD, what is the most common? Please answer that. Correct?
Yes, sir.
Okay. So now, if there is a epidermolysis and torsion, how will you differentiate?
Sir, clinically, by the patient history,
Start
sir.
from
First.
history and investigation. No, I want everything. One side first will be the in the history, epidermolysis, what you see, in torsion, what you see, and what
Sir,
type of history you get.
in first, sir, in torsion, it will be present in a young male, sir, while epidermolysis may be present in old male in the history. Then torsion will be having acute presentation, sir, and acute presentation, while epidermolysis may have acute or acute on chronic presentation. And
Okay.
on clinically, both will be having tenderness, sir. But while we lift the testis in the torsion, the pain will increase, sir, on examination. While in the epidermolysis, when we lift the testis, pain will relieve clinically.
History in epidermolysis,
In epidermolysis,
there may
patient may
not
be
be a
having history
fever.
of any instrumentation or any UTI.
So there is no history of UTI, there is no history of any fever. While in
Yes,
epidermolysis, there may be history of LUTs,
fever and UTI.
infection, fever. Correct?
Yes, sir.
Right. Then clinically, you said that pain will be relieved on lifting up. What else?
Yes.
In epidermolysis, the skin will be very much inflamed. But if you see many a times in torsion, the skin will be little edematous and tethered, like a how you get PUD orange. Similarly,
Yeah. Okay,
you know.
sir. Yes.
Then investigation.
First, I would like to do Doppler, sir, ultrasound Doppler. In epidermolysis, there will be increased vascularity, while in testicular torsion, there will be absent vascularity, sir, on color Doppler.
Okay. And how your management will differ?
In the testicular torsion, if you are confirmed by the ultrasound, you have to immediately explore the testes after the consent proper. And while in epidermoarchitis, we have to give the urine analysis, urine culture, TLC, and start the higher antibiotics, sir.
And analgesic. Anti-inflammatory.
And analgesics.
This is just in short, huh? In short, you may get
Yes.
some, and then you can elaborate whatever you want to do. Okay, fine.
Yes.
Okay. Rahul, please complete the history.
Yes, sir. Patient was relatively asymptomatic 1 month ago when he noticed a swelling in the left hemiscrotum, which was painless, insidious in onset, non-progressive. Patient does not give any history of aggravating or relieving factors of the swelling. Non-negative history, no history of fever, nausea, vomiting, no discharge per urethra, no history of increase or decrease in size on lying down or standing, no history of chronic cough or constipation or hemoptysis, no history of tuberculosis or Cox contact, no history of any trauma, no history of any multiple sexual partners, or any difficulty in micturition or urinary retention or burning. Patient does not have any history of previous instrumentation or catheterization. No history of jaundice, facial puffiness, exertional breathlessness, lower limb edema, or lumpy abdomen. No history of backache, bony pain, weight loss, or loss of appetite. Past history, no significant past or family history. Diet is also normal. Patient is not a addict, non-alcoholic, non-smoker. General examination.
Okay,
Patient
but
is conscious.
fine. No, okay. Just stop. Go back. Okay, fine. So now who is going to answer? What is now the differential diagnosis in this case? You can just summarize. Atul, just summarize. Okay, what is the history and what is your probable diagnosis?
Uh, Sir, this 52-year-old male patient with swelling in the left side of his scrotum for last 1 month. The swelling was, as per history, swelling was gradually increasing in size, and about 1 month,
It has
meaning
gradually increased,
noticed
but it has a
1 month.
gradually but rapidly increase in size. No, it is
Yes,
not
sir.
like the like tunica vaginal hydrocele. It will take almost 1 year, 2 years to become so apparent, right or
Mm,
wrong?
yes, sir.
And if it is an infection or if it is a torsion will be within just half an hour, or patient gets a pain and in half an hour he'll say, oh, my this is this swollen, or the scrotum has become
Yes, sir.
enlarged. Correct. And if it is epidermolysis, patient will have some fever and it's 3-4 hours, and then slowly he'll get next day morning he will see that I have got a big inflamed scrotum with the testes. So these are the different histories. So here it has
Yes,
gradually, but in a very short duration, it has become large. And that
yes, sir.
also there is no pain, no fever, no any other associated symptoms. Correct.
Yes, yes, sir.
So what are the possibilities?
Sir, possibilities maybe, sir, left-sided testicular tumor, uh, tense vaginal hydrocele, or old hematocele, which was recently, meaning um, recently a patient get after during 1 month only he got to know that it is having this kind of problem.
Again,
Then
priority wise, first put the tunica vaginalis hydrocele,
yes, sir.
because you are not yet examined, you don't know anything, and
Yes,
there
sir.
are chances that patient might have seen or realized. See, many a time they don't look at their organs also so often.
Yes, sir. So
Understood?
first one I will take
Mm.
as tense vaginal hydrocele. Then second chronic epidermolysis, and old hematocele or gamma, and then left-sided testicular tumors.
So I want to know how often you have seen testicular tumor and how often you have seen hematocele in your 3 years of or 3 years of general surgery. In these 6 years, how often you have seen hematocele?
Sir, actually, in our center, we were suspecting testicular tumor, but patient when got operated on histopath showed hematoma, organized hematoma.
No, I agree. But clinically, means how often you have seen, and how often you have seen testicular tumor? Which one you have seen more common?
More seminoma.
No, so testicular tumor, na?
Yes.
For example, in your 3 years, you might have come across 3 or 4 testicular tumors. But
Yes,
in
sir.
these 3 years, hardly you will come across one hematocele or hematoma. Right or wrong?
Yes.
And that also when you suspect it because there is a history of trauma.
Yes.
That one case may be little different because he might have forgotten that he had injury. But
Yes.
otherwise, what is most common? Like in every month, you will say at least 2 or 3 tunica vaginalis hydrocele.
Yes, sir.
You will see at least after TURP, you must have seen at least one, epidermolysis in 2 months.
Yes.
And in your 3 years, at least 2 or 3 testicular tumor and hardly any hematocele. So think that way only. Na?
Okay, sir.
What is most common? So that. So in this case, yes. So
Hydrocele,
now,
most common, vaginal hydrocele.
yeah. So now, what are the important investigations you like to do? I
Uh,
mean, sorry.
one,
Sir,
What are the
examination.
examination you like to do?
Sir, first,
one of
Okay.
I would like to examine the swelling is site, extent, shape, surface margin, its consistency, and tenderness is there or not, testicular sensation preserved or not, and spermatic cord examination, then skin over the over the testis, that is scrotal skin examination. Any loss of rugosity is there, mobility over the swelling, like skin is fixed or mobile. Then other like chest examination for gynecomastia and abdomen examination like a liver, spleen, or any lump is there or not. Then other site of lymph node.
Local examination not completed. Sachin, what
Yes.
are the other things you will do in local examination?
So contralateral test is, sir, it is normal or no?
Number one. Number two,
The swelling is hard or soft or firm, sir, and consistency of the swelling.
what else?
Dimensions, the size of the swelling.
What else? Solai Raj,
The pain sensation is there or not? Skin fixity and lymph nodes, local lymph nodes and abdominal lymph nodes and supraclavicular lymph nodes.
but local, what you want to do?
Temperature, temperature, localized temperature raised or no.
Yours, did you say about trans-elimination and
Yes, sir.
fluctuation?
Fluctuation and
Transmission or
transmission.
fluctuation also we have to rule out.
That is the most important, na?
Yes, sir. Yes, sir.
In testicular swelling or in the scrotal, any pathology, if you don't talk of these two things,
Yes.
then in exam you will fail. This is MBBS level,
Mhm.
right or wrong?
Yes, sir. Yes, sir.
Don't miss it.
Yes, sir. Sure.
Okay, Vijesh, show them. So
General
general examination,
examination.
anything?
No, sir.
Nothing.
Normal, sir.
Okay, okay. So Solaraj, in general, in related to scrotum, how many parts of the abdomen you have got?
11, sir.
How many?
11, sir. 11.
Which are they?
Um, right hypochondrium,
Hmm,
epigastrium, left hypochondrium, and
hmm,
umbilical, right and left lumbar,
hmm.
hypogastrium, right and left iliac, scrotal, left supraclavicular.
Okay, so this is the way you put it. 11. Very good. So you like to see the even the generalized all these parts you will like to see, correct?
Yes, sir.
Very good. Fine. Local examination. We have that. Bye. photograph we have got, na? Who wants to describe?
नहीं, 11 what 11 he told, sir?
Pardon?
Left
11 is
supraclavicular, sir.
नहीं,
the 11th, actually 9, but he says that I will remember two more. That is one is the
you remember in your mind. If ask how many numbers of quadrant in the abdomen, then
9.
your answer is 9 only.
9.
Okay, sir.
Don't tell 11 in exam.
Okay, sir.
Yes. Atul, you want
Yes, sir.
to try?
Sir, on infection, meaning on inspection, this mm, swelling is looking like an left sided swelling, left sided scrotal swelling, and um, yeah, left testis is looking enlarged in size and crossing the median raphe towards the opposite side, pushing the right testis to opposite side, and there is no mm, a connection looking from inguinal to scrotal region, sir. And
So
shall we
it is
inspect?
appearing a scrotal swelling, correct?
Yes, sir. Yes, sir.
So this is a left-sided scrotal swelling on inspection. The size is almost, I think you can say about 6, 4 or 5 inches to total, correct? 5 inches by 4 to 5 inches. And it is pushing the penis and the other testes on opposite side. There is no signs of inflammation. There is no, the rugosity is maintained, correct?
Sir.
The skin is not straight. There is no reddening. There is no inflammation. So now,
Okay, sir.
what else you want to do?
If
Examination.
picture is shown in the exam, so you should be very particular and restricted to what is seen only. Don't
Yes, sir.
imagine, don't imagine, don't tell anything imaginary. Left hemiscrotum is enlarged. Swelling looks like confined to the testis, confined to the scrotum. Then overlying skin is normal. Palpatory finding को तुम कुछ नहीं बोल सकते.
No,
Yes, sir.
nothing.
जो दिख रहा है वही बोलना है, क्योंकि अगर क्लिनिकल एग्जामिनेशन के पेशेंट है अवेलेबल तो फिर हर चीज को बताना पड़ेगा.
Correct.
पिक्चर अगर सामने रखा है तो जो भी दिख रहा है उतना ही बोलना है. ठीक है.
So, okay.
Yes.
So now palpation, what are the things you want to see?
Sir, palpation, sir, size and shape, extent, it is above, getting above the swelling is possible or not. Then surface and margin, and on testicular sensations present or not.
देखो
Spermatic cord
पाल्पेशन में
examine.
इसीलिए एक दास नाम का बुक है, उसको पढ़ो. मैं लास्ट सेशन को भी बोला कि पाल्पेशन मतलब हाथ रखे बराबर पहले टेम्परेचर रहेगा, दूसरा सेंसेशन रहेगा, उसके बाद में फिर वो स्वेलिंग है कि नहीं है. स्वेलिंग है तो उसका साइड टेस्टिस के पर पूरा इन्वॉल्विंग होल टेस्टिस है कि कौन सा एक पर्टिकुलर पार्ट को है, तो वो आ गया साइट. फिर साइज, फिर नंबर 1 है 2 है, फिर उसके बाद में फिर फ्लक्चुएशन, उसके बाद में कुछ फ्लक्चुएशन फ्लूइड है कि फ्लूइड नहीं है, टू गेट अबव द स्वेलिंग है कि उसके बाद में टेंडरनेस है कि नहीं. जो पाल्पेटरी फाइंडिंग्स पूरे खत्म कर दो, फिर इंस्पेक्शन बोल दिया तुमने. पाल्पेशन का होने के बाद में फिर अपना ये देखना है कि तो ट्रांसल्यूमेंसी है कि नहीं, वो सब चीज और कफ इम्पल्स.
Yes, sir.
तो ये एक सीक्वेंस में बोल दिया ना तो प्रॉब्लम नहीं आता है.
Okay, Brijesh, Rahul, just show them what are the findings.
On inspection, patient examined in supine and standing position. Then is an irregular enlargement of the left hemiscrotum of size 4 by 6 by 5 centimeter. The skin over the scrotum is normal and smooth. No cuff impulse. The swelling does not reduce in supine position. Right hemiscrotum is normal. Genital examination is normal. No visible lymphadenopathy in bilateral inguinal region, sir.
Okay. Next.
On palpation, a single, fixed, non-warm, non-tender, 5 by 7 by 5 centimeter hard swelling with irregular surface on the left side of the hemiscrotum is present. The swelling is non-fluctuant and non-reducible. Cuff impulse is absent. Transillumination is negative. Getting above the swelling is possible. Right testis is normal in size and shape. Both the spermatic cords are normal. No inguinal lymphadenopathy on both sides. External genitalia normal, sir.
Okay, Sachin, how will you do trans illumination test?
Sir, in the dim light room, patient in supine position with exposed groin from nipple to knee. Then I will like to on the torch and on the opposite side. I'm standing on this side. Then I will put the torch on the opposite side and will look for the any translumination there or no, sir.
The
So where
torch
you
is
put the
placed
torch?
laterally, sir. Laterally. Laterally,
And
not on the opposite side.
and how will you demonstrate? How will you see the trans illumination?
Light reflection will come back, sir. Red color.
what are the things required for seeing the transillumination? लाइट लगा दिया तो कैसा आप खुद ब खुद दिखेगा क्या? उसके लिए कुछ लगेगा कि नहीं देखने के लिए? क्या लगेगा देखने के लिए?
4 or 5 papers we can roll and we can keep on the testis, scrotum.
Which is the best thing?
And
Which is the best thing? Any dark thing. So which is the best dark thing available with you people in hospital?
तो ये क्वेश्चन नहीं ना तो बड़ा मुश्किल हो जाता है. ये एमबीबीएस का है. सो एक्सरे को रोल करके देखो ना.
yes,
सब लोगों ने यूज किया है लेकिन बोलते नहीं है. एक एक्सरे को रोल करके और सिंपल चीज. हाउ मेनी टाइम्स यू मस्ट हैव डन इट इन योर लाइफ?
yes.
And how you are going to fix the scrotum? Huh? Solid as is a small hydrocele. How you are going to fix? You put a torch on one side, the scrotum moves. How you are going to fix it?
So from top and down we have to fix by both. Other person can hold.
But if you don't have anyone, ask the patient to hold it. Na?
Yes, sir.
Ask the patient to hold the scrotum and you can do the test.
Yes,
so which are the cases where you will get a trans elimination negative?
Sir, chronic epidermolysis or testicular tumors or gamma or testicular torsion.
So, okay, which are the conditions of tunica vaginalis hydrocele where you'll get a trans elimination negative? So, number one, there is start from outside when there is a thickened skin secondary to pylorix.
Infection.
Correct?
Pylorix,
okay?
yes.
So you'll get it. Then thickened sac or calcified sac, or there is a chylocele, there is a hematocele, or there is a pyocele.
Yes, sir.
Right? So these are the one of the few of the commonest thing in tunica vaginalis hydrocele where you will get the negative trans elimination. Otherwise, as you said very rightly, when there is no hydrocele, there is enlarged status, epidermal orchitis, tuberculous orchitis. Okay.
Yes.
Now, what are the different types of hydrocele? You know. Sachin?
First, primary and secondary hydrocele, sir. Primary hydrocele is due to the defective lymphatic drainage, and secondary hydrocele may be due to any infection, sir.
Okay. Primary hydrocele, what are the different types?
tunica vaginalis hydrocele, then hydrocele of the cord, sir, scrotal cord, spermatic cord.
Okay.
And patent tunica vaginalis, same.
Congenital, funicular,
Congenital,
infantile,
congenital
encysted
What is that?
hydrocele of cord.
So there is an infantile hydrocele, there is a congenital hydrocele, then encysted hydrocele of the cord, and tunica vaginalis hydrocele. So what is the difference between infantile and congenital? Infantile hydrocele is going up to the, is closed, but it is going up to the internal ring. And congenital, there is a communication,
Yes.
but usually like an ink pot. So you cannot reduce it easily, and it gets filled up when the child, is in a mobile. How will you clinically differentiate encysted hydrocele of the cord and epidermal cyst? Atul?
Sir, epidermal cyst we can palpate at the lower pole, sir, while encysted hydrocele will be on the upper pole.
Both. Even in the head of the epidermis, there is a big cyst, epidermal cyst. How will you differentiate?
Sir, via transimulation we can differentiate both.
No.
Sir, epidermal cyst will be adherent to the testis, sir, and the hydrocele of cord will be away from the testis, sir. Some space will be there.
So when you pull the testis down, the epidermis cyst will also come down with the testis.
Yes.
Then the encysted cyst hydrocele of the cord will not. Second thing, it is mobile, but when you pull it and make the cord taut, it will be like a fix. You cannot move it. Understood? So these
Yes.
are the two important clinical observations. Fine. So tell me how you are going to show fluctuation. Okay, what are the principles for trans illumination? Why you are putting a torch on one side and you are putting the, folded dark color, either paper or X-ray on other side? Just simple
The mo
physics.
the most common
Diffusion of
mistake,
light.
the most common mistake any student from MBBS to MCS does is place the torch on below or above and see from opposite side.
Exactly.
And why it is wrong? Why it is wrong because testis is coming in
Testis is
between.
posteriorly, na? So you
Exactly.
should not put it posteriorly.
So testis is coming in. Testis should not be come in between the paper placed, the roll placed on one side, superior lateral. Both things are lateral. Keep it in mind. कि आप देख भी रहे हो laterally and ये भी तो क्या बोलते हैं उसको जो फिक्स भी किया है टेस्ट एक हाथ से फिक्स करना है और जो रोल है वो एक साइड से एक साइड को रखना है एक साइड को और दूसरे साइड से पेंसिल टॉर्च रखना है तो सुपीरियर लैटरली अबो एंड बिलो ऐसा नहीं रखना है एक पोलर भी नहीं रखना है एंटीरियर पोस्टीरियर भी नहीं रखना है सुपीरियर लैटरली रखना है so that the testis should not become in between the torch as well as the roller paper. This is the very important thing.
Don't forget an exam.
Because this mistake cannot be tolerated by any examiner.
Yes. So just tell us the simple principle. The
So
number one,
diffusion of
light
light.
travels in a
Straight path.
straight path. So that is why you are going on opposite side and you are able to see the illumination. Na?
Yes.
So that is the number one, correct? Second thing is
diffusion of light due to liquids.
Yeah. So what is happening? It is
dispersion.
It indicates the clear fluid. Clear fluid है तो ही light दिखेगा.
वही दिखेगा ना बेटा.
Yes, sir.
So it traverses through the clear fluid. And the third, refraction. Okay.
Yes.
Fine. And now, what are the principle of fluctuation? And how you demonstrate fluctuation? And what are the causes of negative fluctuation? Come on.
Sir, we'll hold the upper pole of the scrotal swelling. Then with one hand make it tense and steady, and with lower pole with the other hand we'll put the pressure. If the above what we have placed the hand, if we are having uh,
No, you have to
fluctuation
say
present, then
everything depends upon the size of the scrotum.
yes,
Okay, the size of the scrotum. If it is a small or moderately enlarged, then you alone can do the test. If it is very big, you will ask patient to hold it. So stretch the scrotum and hold it,
yes,
or just some assistant to hold it, and then you can show the fluctuation. So how
yes.
will you do it in a small swelling? With
So
your
in
thumb
small
on one
swelling,
side, listen, thumb on one side
yes,
and three fingers on other side of both the hands on
mm,
opposite side. Okay,
yes,
you will apply the pressure and stretch the skin so that the scrotum becomes taut. And with your
mm,
index finger on one side, you will press it so that you get the thrill on opposite side.
yes,
That is fluctuation. Correct?
yes.
Now, what is the principle of fluctuation? On which physics law it is based?
Sir, fluctuation and fluid thrill, these are two different
Well,
things.
not fluid thrill, fluctuation. So you will not get a fluid thrill, but you will get your index finger will move. So if you press it on one side, the other index finger will move.
Correct.
So this is based on which law of the physics? Pascal's law. Pressure exerted anywhere upon the mass of the liquid is equally transmitted in all direction and acts perpendicular to the surface. So that is why on
Yes,
one surface you press it, the pressure goes down, but it is again exerted perpendicular in all the direction. So that is why your
yes,
second finger goes up. Okay,
yes, yes.
just remember this. Now tell me which are the cases where you will not get fluctuation.
Sir, where fluid will not be present, like hard swelling is there, and yeah, like tense vaginal hydrocele, old hematocele, or epidermolysis, or where torsion of the testis is there, or testicular tumors are there, then we can't find
Yeah,
fluctuation.
so thickened cord, again the same thing, very thick skin, thickened cord, there can calcified sac. Okay, so there is a thickened or calcified sac. There is a thick pus pyocele, or there is a hematocele organized hematoma,
Yes,
right?
yes,
And very less fluid, large testes, epidermolysis, torsion, all these things. Fine. Okay, fine. Anything else in examination? You
No,
want
no,
to
sir.
show
if
anything?
if they are talking about the testis, then swelling and testis is separately palpable or not, number one. Number two, epididymis is separately palpable or not. Then number three, please comment on the vas also. ये
Yeah.
ये सब चीजें important है. And
Yes.
usually what happen कि except choriocarcinoma, majority time the testis is always enlarged, and majority time it is firm to hard, it is nodular. Secondary hydrocele sometimes present, loss of testicular sensation is commonly seen, and the epididymis is sometimes may not be filled separately from the mass. So ये सब पिक्चर अगर हो रहा है तो मैलिग्नेंसी की तरफ जाता है. अगर वो
Yes,
नहीं है, इसमें कोई भी डेविएशन है, तो फिर नॉन मैलिग्नेंट में फिर बेनाइन में इन्फेक्टिव है कि नॉन इन्फेक्टिव है, ये सब चीजें देखना पड़ेगा. तो कॉमन प्रेजेंटेशन ऑफ मैलिग्नेंसी क्या है? तो एक्सेप्ट कोरियोकार्सिनोमा, एनलार्ज टेस्टिस रहता है, यूजुअली नोडुलर रहता है, फर्म टू हार्ड रहता है, सेकेंडरी हाइड्रोसिल रहता है, लॉस ऑफ सेंसेशंस बहुत बार रहता है, पेनलेस स्वेलिंग रहता है, एंड इपिडिडाइमिस डिफिकल्ट टू फील सेपरेटली. ये दिमाग में फिट कर देना है कि ये ऐसा दिख गया तो मैं उसको मैलिग्नेंसी बोलने वाला.
yes.
Hmm. So, Rahul, just tell us what are the findings?
Yes, sir. A single fixed, non-warm, non-tender 5 by 7 by 5 centimeter hard swelling with irregular surface on the left side of the scrotum. The swelling is non-fluctuant and non-reducible. Cuff impulse was absent. Transillumination was negative. Getting above the swelling was possible. Right testis is normal in size and shape. Both the spermatic cords are normal. No inguinal lymphadenopathy, and external genitalia was normal. Examination was done. Prostate grade 1 was firm in consistencies with smooth surface, non-tender, while rest of the examination was normal. So
Okay,
this is the end of the examination.
fine. But please remember, how will you examine is the skin? Then you are going to see the testes, whether the testes and the swelling, whether you are able to palpate the epidermis or not, whether any cystic lesion of the epidermis, then the cord, whether it is a normal cord, thickened cord, beaded cord. Once in a while, you'll get a beaded cord also. And if we get such cases, then we always keep it in exam. So, like a tuberculosis. So, please understand that you have to examine, then reducible, irreducible, all this thing. Fine. Now, what you want to do? Solai Raj. Solai Raj, you are there? Sachin, you answer.
Sir, abdominal examination, he mentioned, sir, abdomen.
Yeah. Rahul,
Abdomen.
Rahul, complete the full examination. Anything in
Sir,
the abdomen, in
no, sir. Abdominal
supraclavicular,
examination was normal, sir.
any
And
lymph node
left
palpable?
supraclavicular.
Left supraclavicular, no lymphadenopathy was present, sir, and inguinal lymph nodes and nothing was enlarged, sir. Overall general,
Chest examination. Any gynecomastia is there only?
no, sir.
No, no, it was not there.
Any loss of sensation, testicular sensation or?
No, sir. Nothing like that.
Sir, in this is a 52-year male, sir. So we should ask family is completed or no, sir.
Yes, of course. Sexual life and family
Yes,
is
sir,
complete or not.
Yes, sir.
Very important.
That was not mentioned, sir. Family is completed or not.
Why?
How
Because
to
see,
check fertility issues?
sometimes it is important. Why? In India, see, we have got that mindset that we are married only to one person and we don't want any children. But believe me, we come across so many patients from UAE and other places. They are more than 60 years old. They have got more than two wives. The third wife or second wife is very young. They have got seven children, but still they want more children. So what you are saying is absolutely right. I will agree with you. Must at least complete your history.
And sir, all ages we should give for sperm banking, sir. Means whatever age we
No,
found the tumor.
no, if he has completed his family, he is not sexually very active and all this. Why you want to do it? But if they want child, yes, then you must do it. Okay, fine. Show me. Now, what you want to do, Atul? This is a history. This is the examination. You have come to a probable diagnosis. Now, what you want to do?
Sir, I would like to have a lab investigation where I'll do a complete hemogram, liver function test, kidney function test, serum electrolyte, and high frequency ultrasound, and also baseline sperm count with serum tumor marker also. I'll do.
Okay, fine.
Do you
Yeah.
do all these investigations routinely in your OPD when you see the patient with testicular mass?
Sir, I'm suspecting, sir, testicular tumor, so I would like to.
What you write on your paper routinely? Don't tell theory.
Sir,
This is practical exam. मैं testicular mass तुम्हारा diagnosis है तो exactly तुमको next sitting में क्या है serum electrolyte क्यों करेंगे?
Ultrasound, complete hemogram, LFT, KFT, sir.
हाँ, and उसके साथ में
Sperm count.
When you decide to go for marker, if your clinical diagnosis is testicular tumor, do you want to do marker or don't want to do marker?
So still I would like, because if in
only
some tumors
you will
only
decide only
S1.
after sonography. So sonography will tell that this is testicular tumor or not.
Sir, if serum tumor marker alone is elevated, then also we should suspect that it can be occult
मार्कर
tumor.
करेंगे कि नहीं करेंगे? कब
करेंगे सर.
करेंगे तो कब करेंगे?
Uh,
What when you will do marker in your routine day-to-day practice at your center?
Sir, if a high index of suspicion is there for
No, you are
tumor.
clinical diagnosis is testicular tumor.
सर अगर अल्ट्रासाउंड पे फाइंडिंग हमको मिल रहा है कि अगर हाइपोइक लेजन है जिसमें होमोजेनस या हेट्रोजेनस को टेक्सचर भी मिल रहा है साथ में,
So if you are doubt, if you have confusion with some other diagnosis, then you may have to go for sonography and confirm it. But if you are clinically perfect, your diagnosis is there. Because one of the most common differential diagnosis is epididymitis, जो कि clinically differentiate होता है.
Yes.
और टेस्टिकुलर मास अगर तुमको परफेक्टली लग रहा है तो मार्कर करना है ना. कब आज अभी नहीं तो थोड़े दूसरे दिन फिर उसको प्रिक करना पड़ेगा.
Yes.
In spite of electrolyte, I will place marker primarily.
Yes.
ठीक है, जो पूछा है वो दिखा दो फिर.
These were the blood reports of the patient, and in the tumor markers, significant LDH was 478, beta HCG was 4.78, alpha fetoprotein 1.28, and rest of the other investigations were normal. With HbA1c are mild elevated 7.1.
Next
Immediately
ultrasound
next question will come. What are the normal range of tumor? Because investigations are look like normal except HbA1c.
Yes, sir, it's normal.
But what are the normal level of the markers? LDH का normal क्या है? Beta HCG का normal क्या है? Alpha fetoprotein का normal क्या है?
Sir, alpha fetoprotein is less than 1000. Beta HCG is less than 5000, and LDH is less than 1.5 units. This is S1 value. S2 is alpha fetoprotein 1 to 10,000. Then HCG is 5 to 50,000, and LDH will be 1.5 to 10 units. And S3 will be greater than 10,000 alpha fetoprotein, and greater than 50,000 is beta HCG, and greater than 10 units is LDH. This is S3.
My question is not about the S1, S2, S3. My question is, what is the normal beta HCG? क्योंकि किसको नॉर्मल बोलना है वो पहले पता रहना पड़ेगा ना.
सर मेल के अंदर बीटा एचसीजी तो होना ही नहीं.
वही, इसका मतलब क्या है, हमने पढ़े नहीं है. ठीक है, नॉर्मल अल्फा फेटोप्रोटीन बोल दो. ये इसके नीचे नॉर्मल बोलेंगे. ऑरेंज है तो नॉर्मल बोलना है क्या? कि 10 आया तो नॉर्मल बोलना है.
Less than 40 is normal, sir, alpha fetoprotein.
40.
Yes, sir.
कंफर्म करो. मेरे ख्याल से लेस देन 10 नैनोग्राम पर ml and beta HCG less than 1 नैनोग्राम पर ml. ऐसा that is नॉर्मल रेंज ये है. मैं गलत भी हो सकता हूँ, कंफर्म कर दूं. बीटा HCG less than 1 नैनोग्राम पर ml, अल्फा फेटोप्रोटीन less than 10 नैनोग्राम पर ml.
In here, it is beta HCG 1 to 5 is normal. So here
Yes.
it is 4.78. And alpha fetoprotein 1.28 है, that is also normal. I think उसका range up to 10 है.
Okay.
Protein.
But I'll find out from our laboratory and we'll post it tomorrow.
अल्फा फेटोप्रोटीन less than 10 चाहिए. बीटा HCG less than 1 नैनोग्राम चाहिए. It is called as normal. नेक्स्ट उसका क्वेश्चन आता है कि हाफ लाइफ क्या है, क्योंकि ये सब चीजें यही पे अटक जाती है। ये
Sir,
दोनों
alpha fetoprotein 5 to 7 days, LDH is 24 hours, and beta HCG is 24 to 36 hours.
वेरी गुड। तो फिर ये पता होगा तो तुमको आगे पोस्ट ऑफ जब डिस्कशन चलेगा तो उसके ऊपर काम को आएगा, कब रिपीट
Yes.
करना है क्या सब चीज, ठीक है। तो
Yes.
अभी ये ट्यूमर मार्कर के साथ आपका क्या ओपिनियन है, क्या पॉसिबल क्लिनिकल, क्या हिस्टोलॉजिकल डायग्नोसिस आने का चांस? एलडीएच बड़े वाला है एंड बीटा एचसीजी नॉर्मल है और अल्फा फेटोप्रोपेन भी नियर नॉर्मल है, ज्यादा कुछ बड़े वाला नहीं है। तो ओनली एलडीएच इज प्रोग्नोस्टिक मार्कर और डायग्नोस्टिक मार्कर?
LDH is, sir, prognostic
Prognostic.
marker. It decides the meaning. It tells the burden of the disease, sir. And also the number of copies of isochrome 12p chromosomes, because it is released by, meaning it is made, protein is released by chromosome 12 number.
सो फिर अभी यहाँ क्या रह सकता है? सेमानोमा रह सकता है, एम्ब्रियोनल कार्सिनोमा, कोरियो कार्सिनोमा, क्या रहेगा ये ट्यूमर मार्कर के साथ? चांसेस क्या है?
सर चांसेस है सर कि नॉन जीसीएनएस डिराइव्ड ज्यादा लग रहा है सर, क्योंकि इसमें एलडीएच का लेवल उतना बड़ा हुआ नहीं है।
फिर बाकी भी तो बड़ा नहीं है ना, बाकी कौन सा बड़ा है? बेटा एससीजी 4.78 रेंज के अंदर ही है, उन्होंने जो रेंज दिया 1 to 5, कोई भी मार्कर बड़ा नहीं।
टेराटोमा में कोई भी मार्कर नहीं बढ़ता ऐसे एग्जाम।
टेराटोमा में भी नियर अबाउट 50% केसेस में बेटा एससीजी बढ़ता है और नियर अबाउट 64% केसेस में अल्फा फेटोप्रोटीन बढ़ता है। एलडीएच सिर्फ सेमानोमा टेराटोमा में ही बढ़ता है, समझ गए? हाँ, तो अभी क्या निकलता है देखेंगे, आगे चलेंगे, आगे बोलो।
आगे अल्ट्रासाउंड,
सोनोग्राफी दिखाओ।
एलडीएच इज उधर महेंद्र पाल सर लिख रहे हैं कि डिसीज बर्डन, इट इंडिकेट्स द बर्डन ऑफ द डिसीज।
बर्डन ऑफ द डिसीज।
Mahendra, you can please
नहीं
throw
सर,
some light on all these
बात
things.
करने का थोड़ा सा ये तकलीफ है, तो
नहीं सर,
ये क्या बोलते हैं उसको, चैट बॉक्स में।
So, sir, discussion is okay. Sir is absolutely right. If beta HCG and AFP is normal, so the very unlikely it can be the NSGCT except the teratoma. And again, if LDH rows can be semiloma or maybe a teratoma only. But atypical NSGCT sometimes represented that way, but again, it is a rare thing. So we should go with these two entities. And we should not decide the type of tumor based on only LDH.
agree.
Yeah.
चलो, what next?
Sonography दिखाओ।
Yes, sir. Metastasis was enlarged and measures 8 by 4 by 6 centimeter with a heterogeneous mass lesion within with partially ill-defined margins. It measures 5.3 by 4.8 by 4.4. There is a reduced flow in the center of the mass lesion. Increased inflow is seen at the periphery. Left epidermis is normal, no evidence of hydrocele. Right testis is normal, and right epidermis shows a small cyst, suggestive of a less testicular mass lesion, very semi-normal.
So what else you want?
So in this stage, I think residents should know what are the USG finding of classical semiloma and the non-semiloma.
Sir, this is looking like NSGCT because it is heterogeneous, and if it is homogeneous, then it will be seminoma. Normally, the germ cell tumor will look hypoechoic on the legend, but here nothing is written hypoechoic or hyperechoic like that.
I want to say that you all must know how to differentiate on USG finding, whether it is a semiloma, or the non-seminoma. Okay.
Yes, sir.
And the next suggestion is core biopsy. What will you do now?
Biopsy should not be done, sir, in this case. Because if we are suspecting malignancy, then tumor can spill, tumor cells will spill, sir.
So what is the harm of it? What will happen
Can
if
cause
we do?
implantation of tumor cells in the path of so upstaging of the tumor will be there.
And
What is the
Scrotal
pH of the skin?
So scrotal lymphatics will be violated, and the tumor will migrate up to the inguinal lymph node, sir.
yeah, so stage will
So stage will
increase.
become metastatic, sir.
Correct.
Yes, yes, right. So
Good.
again, FLAC we can be done safely. And second, if biopsy is needed for certain indication, the coaxial technique can be used for the same. Okay. So sometime examiner may ask in which condition you want to do a biopsy. So you can say if in the same patient, if other test is shows microlithiasis, right? And that is highly suspicious of intrapresumption neoplasia on the sonography, then you can plan for the uh, coaxial biopsy or FLAC. Otherwise, for the normal testis, there is no need for biopsy to the disease testis. Okay, yeah, go ahead.
Fine. So now next, what you want to do?
Sir, we'll go for orchiectomy, sir.
So now you want to do orchiectomy first, or you want to do the CT scan first?
Sir, orchiectomy, because this is
Do you,
looking like
do you want do
clinical
you
stage 1 disease, sir.
do you want to evaluate before going for orchidectomy abdomen and chest by doing radiological investigation or not?
Sir, if we are suspecting metastasis or orchiectomy serum tumor marker elevated, then we'll go for CT chest, abdomen, or pelvis. If they are normal, then no need of that actually. If depending on the pathology, we'll decide further, sir.
So at present you don't want. Correct?
No, sir. Yes, sir.
Mahendra, what is your
So, sir, I will just ask the person the same question. Ki suppose that if HIO, the HPR comes as seminoma, will you do CT scan or not? Because it is matching with the sonography finding, ultrasound or the scrotal finding as seminoma. Will you do CT scan or not?
Bye.
Please
Sir,
answer.
if it is coming non-seminoma, sir, then we will go for.
No, I'm giving you scenario. It is coming seminoma only, pure seminoma.
Sir, then we can do, sir, CT, MRI, or CT or MRI abdomen plus pelvis.
You just
But
said
there is no need of chest X-ray or CT chest, sir.
okay. Why? Seminoma will not spread to lungs.
Sir, but it's clinical stage 1, that's why it's not an
How
advanced
do
disease.
you,
So,
how do you know it is clinical stage 1? What is the clinical stage 1 TNM classification?
sir, either 1A, 1B, or 1S.
That's all. Nothing else included in that. TNM. You need to see NNM, na? Based on
Yes, sir.
based
1A
based on
meaning
only
T1 only, 1B is a T2 to T4, and 1S is meaning serum tumor markers are positive, whether disease present or not inside the testis. If S1 meaning tumor is not present, only serum tumor marker are elevated. That means it's clinical stage 1, sir. 1S.
So you want to stage the TNM staging of testicle cancer based on T and S1, not the N. So you don't want to search for the N staging and M staging. That means abdomen में nodes है कि नहीं है, lungs पे मेटास्टेसिस नहीं है कि नहीं है. How are you are so sure based on USG scrotum and based on your HPR?
Sir, on meaning first we have to check the nodal status, no? Then only we can tell.
How will you check? Based on USG scrotum or based on HPR of hymenopterectomy? I only ask such extensive questions to you to realize that in malignancy, for any staging, you have to find out TNM status. And for
Yes.
TNM status, the whole body imaging is required, right? And
Yes.
either it is a form of CT scan or the PET scan, but CT scan is the most commonly and investigation of choice of most of the cancer while diagnosing in the initial evaluation of the cancer. And CA and always remember, everybody remember CA testis में CT scan chest and abdomen pelvis is mandatory in initial evaluation to stage the disease. And in malignancy, you always have to stage the disease before deciding any treatment options. Is it clear to everyone?
Clear
Yes.
to everyone? So in exam, don't stop at sonography and just go for a orchidectomy, high orchidectomy. Please talk about this. That is why I asked Mahendra. Thank you, Mahendra, for clarifying it.
Yes.
Yeah.
The only thing is
Okay.
that,
Now, yes.
but just I want to add, sir, if this testicular mass having torsion, it is an emergency, you can proceed with HIO and then you can do CT scan. Because sometimes examiner may ask in which condition you want to do orchidectomy first. So this is the only sometime this here testis comes with the torsion of testis. Okay, in this scenario you can remove the testicles and then do staging workup later.
Okay.
Sir, chest X-ray should we do initially or no need, sir? Directly should we proceed for CVCT? Chest, sir.
It is CT scan. It is non-contrast CT scan of the chest with contrast enhanced abdominopelvis.
So if you are talking about chest X-ray, how many percentage of metastasis is missed in the chest X-ray? And it is missed in which place of the lung, which part of the pleural cavity? .5% of the metastasis, particularly in subpleural area, is missed on the chest X-ray. Okay, so that's why sir, what sir is telling is it is important.
Okay. Rahul, have you done investigations, CT scan?
Yes, sir. We have, sir.
Show them.
Yes, sir.
Only one film or all the films?
And another film is there, sir. I'll change, sir.
Okay.
Can I go with the reporting, sir?
Yeah.
Retrograde.
See, over CT scan of the chest, abdomen, and pelvis was done. Overall findings of the chest were normal. There was an enlarged left para-aortic lymph node noted near the origin of the left renal artery, largest measuring 2.1 by 1.9 centimeter, indenting the left renal vein. The visualized left testis was enlarged in size, measures 7.9 by 7 by 5.8 centimeter, and shows heterogeneous post-contrast enhancement with a hypodense non-enhancing well-defined area within the testis, measuring 2.5 by 1.7 centimeter. Engorgement of the venous plexus is seen, suggestive of varicocele. The left testicular artery also appears prominent. These were the major impressions in the CT, sir.
Yeah.
So, CT is useful before going for orchidectomy.
No, sir. We can postpone it also. After orchectomy also we can do CT.
Just now we told CT is mandatory. Told by Mahendra. Still you are telling same answer.
Because he did not
Sir,
find
management will change, sir. Management wise it will change. If
No.
metastatic disease is there, then
देखो ये सिटी में अभी कुछ तुमको एडिशनल इंफॉर्मेशन मिला है नहीं मिला है?
yes, sir, yes.
क्या मिला है?
Left para-aortic lymph node enlargement is there.
उसका क्या मीनिंग है? क्योंकि कुछ भी बोलना है ना तो बोलने के पहले सोचना है, एग्जाम में पक्का ध्यान रखना है। जो भी कुछ बोल रहे हो उसको डिफेंड अगर नहीं कर पाते हो तो नहीं बोलना है।
Yes, sir, yes.
और ये नेसेसरी नहीं है कि सामने वाले ने पूछा कि इमीडिएटली आंसर देना। 10 सेकंड के लिए सोचो ना। तुम ये गलती करेंगे बोल के ही मैंने डबल पूछा था।
Sir, left para-aortic lymph node is the landing zone for left testis. So it is positive, sir.
साइज ऑफ द लिम्फ नोड कितना है? साइट है क्या? प्रॉपर लैंडिंग जोन में साइट है क्या? और उसका क्या क्या इम्पैक्ट ट्रीटमेंट पे?
Sir, it is more, meaning it is range is 2 to 5 centimeters, sir. 2.1 to across 1.9 centimeter. So meaning it will be N2, sir. N2 category.
N2 पे आ गए हो? अभी आगे बोलो।
Yes, sir.
क्या करेंगे?
Sir, N2 will be stage 2, sir. Clinical stage 2.
When will you give chemotherapy without testicular orchidectomy?
Sir, if advanced metastatic disease is there and emergency is there, meaning then we have to give chemotherapy before orchectomy.
Okay. One more indication is poor performance status.
Yes, sir.
And sometimes medical oncologists also give without doing the biopsy in above 2 conditions.
Yes.
ठीक है, अभी इसमें क्या करेंगे?
So now what you want to do? You want to treat without diagnosis or with diagnosis?
Sir, pathological diagnosis we need, sir.
So how will you obtain the pathological diagnosis?
Via high inguinal orchectomy.
So how will you do high inguinal orchidectomy?
Sir, we'll give inguinal incision, sir, and then we'll clamp the cords before this deep inguinal ring to avoid the tumor cell going into the system, and then we'll do, sir, with cord we will remove the.
How many arteries you will apply?
Sir, we usually apply 6 arteries.
Why?
So because these are the spermatic cord has a these testicular arteries are very tortuous in nature, so there are high chances that it will go off and slip and it will cause torrential bleeding. So we should apply 6 arteries and then artery forceps, and then we'll ligate them by transfixation, and then
So
we'll
where you
cut
will
the
cut?
cord.
Which one? How many arteries you will cut?
Sir, first and second, sir, from
From which side, first and
proximal
second?
proximal to distal, sir.
So distal to proximal is first and second. So 5 arteries you will let it go with the tumor.
Meaning, sir, will
The
ligate
testicular
for
size, from the testicular side, you have applied 6 arteries, correct? As per you.
yes, yes.
Then from the testicular side, after how many arteries you will cut it?
Sir, first and second from the tumor, sir. Meaning we can cut, and
So
above that we can ligate.
so 5 arteries you will just keep it. Why you want to keep 5 arteries proximal to the cut? What is the scientific basis behind that?
Sir, uh, it will give safety of like torrential bleeding will not be there if we ligate
So when
more number
have you
of
done?
times.
1 minute, 1 minute. Have you assisted in donor nephrectomy?
Yes, sir.
So in donor nephrectomy, when you are cutting the vein, which is much bigger than this, correct? And that the bleeding from that vein and artery will be very torrential. You agree?
Yes, sir.
How many arteries you are applying?
Sir, we are applying only 2 there.
Then why 6 over here? Hmm?
Sir, in between arteries also will ligate.
So not more than 3. 3 is enough, because if you handle, then the tumor cells may come up to the distal most, means the one which is very near to the testes. So maximum 3 or maximum 4. So between 2 and 2 you can ligate, you can cut.
Yes,
So
sir.
2 proximal and 2 distal, and between 2 you can cut. So that there
Yes,
is no spillage of any
tumor,
tumors
sir.
cells. Okay.
Okay, sir.
Okay. Mahendra bhai, please, some important questions you want to ask.
Yeah.
So what are the indications for biopsy?
Two, three,
Hello. Sir, can you hear me?
2, 3 basic. Okay, go ahead, sir.
Yeah. So in HIO, your first aim is to control the spermatic cord and the internal inguinal ring. Never try to handle the testicular mass before taking control of the spermatic cord, because the handling of mass may lead to
Correct.
seeding of the tumor to the spermatic cord. So, as sir said, three artery, 4 artery, or 2 artery is enough. Only thing is that you apply the transfix the proximal stump of the spermatic cord very carefully with the non-absorbable suture. So when during the RPLND, when we remove the gonadal vein, so we can identify the distal part of the gonadal vein with this non-absorbable suture. So you should try to take control of the spermatic cord and the internal inguinal ring, and then after ligation or cutting it, then you can do whatever with the tumor, and whatever pressure you can apply, you can do that. It will not lead to any danger or risk of tumor seeding after this. Yes, sir.
So what is meant by Chawasu manure?
Atul,
Uh,
Answer?
I couldn't recall, sir. I have read it, but I forgot.
कब करना है, क्यों करना है?
Chivas manure is for testis sparing surgery, sir.
So when you will do it?
When, by applying a soft clamp to the cord and the testicular artery, when the whole the testis is dissected and brought into the operative field to avoid that spillage of the malignant cell, that is already explained. After seeing the testis along with the mass, if you have a doubt it is a malignancy or it is not malignancy, then we have to bisect the testis and see inside the testis, send something for the frozen and confirm it is malignant or not. And if it is not malignant, then to close the testis. Correct. So this is what is the Chavasu manual. Suppose you have explored the testis transcrotally already, unknowingly, then what is the course of action? तुम्हारा जूनियर ने आके वो ट्रांसपोर्टल ओपन कर दिया, अब क्या करेंगे?
Tolerized is there?
No, sir.
सिर्फ टेस्टिस निकालेंगे या फिर और कुछ निकालेंगे या क्लोज करके छोड़ देंगे, रेफर कर देंगे?
Atul, logically what you will do?
Sir, we should remove the scrotal wall also with testis.
Hemiscrotectomy with archdectomy.
Yes.
Yes.
Correct. And as well
Yes, sir.
radiation to the inguinal region.
Yes, sir.
So archdectomy, high radical inguinal archdectomy का क्या रोल है? थेराप्टिक है कि डायग्नोस्टिक है?
Sir, diagnostic as well as therapeutic both. डायग्नोस्टिक में हमको टिश्यू हिस्टोलॉजी पता चलेगा, जिससे हम आगे का फॉलो अप प्लान कर सकते हैं, सर्विलेंस प्लान.
So it is a histology as you told, then it will be local staging. And therapeutic में क्या होगा? It is decreases the tumor burden.
It is curative in stage 1 tumor, sir.
It is curative in which tumor?
Clinical stage 1.
Spermatocytic seminoma.
Spermatocytic
Where
tumor.
benign lesion.
Stage 1. Okay, and it decreases the tumor burden. These are the three important therapeutic role of the radical archdectomy.
Yes.
So what is meant by fascia preserving archdectomy? Fascia preserving radical archdectomy. So subinguinal incision without opening the external ring. Okay, the preservation of fascia camper and fascia scarpa and external oblique fascia. तीनों fascia को preserve करना है, open नहीं करना है. Subinguinal incision लेना है without opening the external ring.
Yes.
It is described in clinics of North America. अपना जो DNA है उसका. ठीक है, आर्कोडक्टमी और कुछ पूछ सकते हो तो सर पूछो, जितना जरूरी था उतना तो पूछ लें.
Okay, so when you will do the testicular preserving surgery?
When solitary testis is there, sir, and bilateral testicular tumor.
Low volume disease.
So what do you mean by low volume?
Low volume, sir, both tumor burden is very less, meaning less than 1 centimeter.
Less than 30% of volume, sir. Less than 30% volume.
Okay. Or less than 2 centimeter. If the big testis, then 2 centimeter. Otherwise, percentage. Fine. Actually, there are many things we have to ask. In one class, it is not possible because now depending upon the
testicular tumor is very big topic.
Yeah. So here we'll just see the final diagnosis, okay,
Yes.
and we'll conclude. What is the final diagnosis?
Yes, sir. Left, post left
Non-Hodgkin.
triangle orchidectomy, non-Hodgkin lymphoma of diffuse large B cell type, non-GCB phenotype by Hans algorithm.
Okay, so this was a twist in the tail. But actually, if you go to see retrospectively, we can suspect it because the lymph nodes were quite a lot, and if you examine the testes, now it was a totally a different type of mass which was palpable as far as the testis is concerned.
Yes.
But idea is that always whenever in when the LDH and alpha fetoprotein, beta HCG, all these things are not raised. Okay, one
Consider
of the probable diagnosis is also this lymphoma.
Yes.
You
Uh,
will come across only once or twice. This is the third time I have come across in this last 35 years, but it is possible.
sir, what was the age of the patient?
54.
54.
Yeah, 54. Yeah, he comes in that age group, 54.
So now actually, this is the last clinic. Okay, but we will start after your exams are over for the practicals. Now we will start first clinic with the continuation of this case only. We'll have another case also, and then we will discuss how to answer in exam, depending upon the the lymph nodes, chemotherapy, radiation, RPLND, and that time we'll request Mahendra Pal and both to be prepared and give the proper guidelines. Mahendra, is it okay?
Yeah, yes, sir, fine, sir. Only thing
Because
is
their
that
exams are on, the thing is their exams are on 29th of October and they are studying for the exams. So, we cannot take one more clinic now. It is too near to their exams. And
that
this
is
is
fine,
more
sir.
of the practical. We can discuss it
Mhm.
after their theory exam.
Yes, sir, I want to advise them after the theory exam, they should make the uh, list of the cases that usually asked in the exam. Then I think sir that USI का जो book है ना अपना
Now,
उसके through they can go ahead and it will help them कि how to answer in the exam. Rest practical part we will always guide them, but if they can read that book also, it will be
yeah,
very helpful for them.
अपना
okay.
पे यूएसआई का अनदर बुक भी आ रहा है क्वेश्चन के हिसाब से, तो अभी थोड़ा टाइम लगेगा शायद ये बैच को हेल्पफुल अवेलेबल नहीं होगा, लेकिन नेक्स्ट बैच को डेफिनेटली अवेलेबल होगा। टॉपिक
Anyway,
वाइज,
we will.
सब्जेक्ट वाइज क्वेश्चंस, जैसा कि रिकंस्ट्रक्टिव यूरोलॉजी में 18 टॉपिक्स या 18 क्वेश्चंस वी हैव डिसाइडेड एंड आई हैव रिटन दैट ऑल द 18 टॉपिक्स। तो क्योंकि एक शॉर्ट केस कैसा लिखना है एग्जाम में या लॉन्ग केस कैसा लिखना है, तो वो एक सैंपल बुक बना रहे हैं। प्रोबेबली दैट में बी हेल्पफुल टू ऑल द स्टूडेंट्स इन फ्यूचर। बट अभी जो थियरी तो होने दो, थियरी के बाद में जैसा भी चांस मिला वैसा एक 8-10 केसेस का लिख के प्रिपरेशन करके रखो। वी आल्सो ट्राई टू मेक इट हाउ टू टेक द केस एंड व्हाट आर द थिंग्स टू बी आस्क्ड। 3-4 लोग मिलके हम भी बना देते हैं और आपको शेयर कर देते हैं।
Yes.
During mock exam, sir, we can share it.
यस,
Yes,
100
Yes,
100
yes, sir. Yes, sir.
definitely. We'll do that. And first or second week of November, we are most probably arranging the mock exam. And in that mock exam, there will be like every student for half an hour he will be examined for a case and half an hour for one table. And then they can sit wherever they want. They can listen to. So we will have the 6 tables, three for the thing. Case presentation and 3 tables for instruments, pathology, x-rays, and on each table there will be 2 teachers.
So
Start from Saturday
from
afternoon and finish in Sunday afternoon.
from all of us, all seniors and teachers, you आप सबको best of luck for exam. Do well in the theory, and
Yes.
where they are available for practical always.
Yes.
Good luck
So
to
all
all
the
of you.
best and
Yeah.
read well and do extremely well in your exams.
Thank you, sir.
And see you after your exams. Okay?
All
Okay.
the
Thank you.
best.
Okay, thank
Good
you.
All the
luck.
best.
Good luck. Bye
Good
bye.
night.
Bye, sir. Gite sir, Gaurang Shah sir, Mahendra Pal
Yes,
ji.
bye, Hiren.
Bye,
Mahendra,
sir.
thanks
Bye.
for the
Thank you, Mahendra bhai.
contribution.
So Astik, thank you for listening and happy Teachers Day to all.
Thank you.
Same.
बाकी जो देवराज चाहिए.
Yeah.
Okay.
Yeah.
Bye-bye.
Bye bye.
Bye.